Welcome back to the deep dive. Today, we're digging into some foundational orthopedic texts. Insall Scott, Tria, Jones, focusing on what feels like a lost art sometimes. The clinical knee exam.
It really does feel that way sometimes. I see countless MRIs, truly countless. And the biggest reason a workup goes sideways, it's rarely the scan quality. It's usually, an inadequate physical exam beforehand.
Right.
Even with 3 Tesla magnets and fancy sequences, you just cannot replace putting your hands on the patient. It's absolutely the cornerstone.
That's exactly what we're aiming for today, Professor, to really lay out that definitive workflow, the kind of step-by-step process that honestly separates the novices from the surgeons who know the pathology before the patient even hits the scanner.
Precisely. Our mission, if you will, is to extract that essential clinical sequence from just watching the patient walk in all the way to those really nuanced ligament tests.
And for everyone listening, especially trainees, this isn't just about passing rounds. It's about getting better and faster at diagnosing.
Oh, absolutely. If you master this sequence, your diagnostic accuracy just leaps forward. Relying only on imaging, it makes you lazy, clinically speaking. It dulls those essential skills.
It really does. The history and the physical exam, those are the whetstones that sharpen your diagnostic mind. Think of it like this. The MRI might be the final receipt, okay? But the clinical exam, that's the careful audit that tells you exactly where every penny went, why the account is off. I like that analogy. History as the map, and everything else is just confirming the coordinates on that map. So let's start right there. Section 1, laying the groundwork with history, observation, and the critical geometry of gait.
History first, always. It's completely non-negotiable. You're not just asking, hey, does your knee hurt? No.
Right, need details.
You need a granular, complete description of the mechanism of injury. If the patient tells you, I was playing soccer, planted my foot, felt a pop, non-contact, kind of a valgus twist.
You're already thinking ACL.
90% of the way there. ACL, maybe a secondary meniscus tear. That history gives you the vector. If they say, direct blood to my shin, knee bend, you're immediately thinking PCL. The story directs the entire rest of the exam. It tells you what damage to look for.
And knowing what to look for based on that story, that mechanism directly influences which tests you're going to emphasize later on. It makes the whole process more efficient.
Exactly.
So once we have that story, we move to observation, the driveway exam, as some call it.
Yeah. The second they walk into view, or even down the hall, you're assessing, can they walk? Are they using crutches, a cane? How fast are they moving? What's their face telling you? This isn't just idle observation. It's immediate data gathering.
And probably the quickest way to confirm the involved side is that gait analysis, specifically looking for the antalgic signal.
The classic antalgic gait, yes.
Yeah.
That telltale shortened stance phase. The patient is, subconsciously minimizing how long they bear weight on the painful side. It's like a quick hesitant step, get the weight off.
You have to be careful though, right? Distinguish it from a short leg gait.
Crucially important. You absolutely must check for a true limb length discrepancy. That could be the primary driver, causing knee pain that's purely compensatory because their mechanics are off baseline.
Yeah.
So yes, rule that out.
Okay. And as they're walking, we're not just clocking the pain response. We're looking at their overall alignment dynamically.
You're watching for varus or valgus alignment, obviously. But the real clinical gold, especially for planning, is seeing a medial or lateral thrust during that stance phase. As they put weight down, does the knee suddenly kind of buckle or shift inwards or outwards?
Like a visual jerk.
Exactly, that visual jerk, that thrust. It screams significant instability. Ligamentous laxity, maybe advanced arthritis causing compartment collapse, like in figure 3.1.
Yeah.
Seeing that immediately tells you you're dealing with serious pathology, probably grade 3 level stuff. Which brings us neatly to the difference between watching them move and actually measuring things statically, the technical geometry. Anatomic versus mechanical axis. This trips up a lot of junior residents. It does, but the distinction is absolutely vital, especially if you're planning any kind of alignment correction like an osteotomy or a joint replacement.
Yeah.
The anatomic axis, that's what you measure in clinic.
Goniometer.
Right, applied externally. Midline of the femur, midline of the tibia, centered on the patella, like in figure 3.2. It gives you that femorotibial angle, usually 5 to 7 degrees of valgus. It's a quick clinical check.
But that doesn't really tell you how the forces are going through the joint, does it?
Nope. For that, you need the mechanical axis. That's the true functional assessment, the plumb line of the leg. And you need a specific x-ray for that. A standing full-length leg film, hip to ankle.
Like figure 3.3 shows.
Exactly. It's that imaginary line from the center of the femoral head straight down through the knee center to the center of the ankle. That line tells you where the body's weight is actually distributed across the tibia. If that line falls way medial or way lateral to the knee center, that compartment is getting hammered, chronically overloaded.
So the anatomic is the general shape, mechanical is the functional load-bearing. Got it. We also need to get range of motion documented early.
Fundamental.
Yeah.
Active and passive ROM. And critically, we define full extension as 0 degrees. That's the standard, period. Any deviation from that 0 mark is significant.
Okay, so what if they can't get to 0? What are the potential causes we need to differentiate?
Right. Inability to fully extend isn't just one thing. It breaks down into 3 main categories, and they have very different implications. First, you might have an extension lag.
Meaning they can't actively straighten it, but you can?
Exactly. Usually pain inhibition, maybe quadriceps weakness, especially the VMO shutting down, but passively you can get them to 0. That's mostly muscular pain related. Rehab usually fixes it.
Okay. Second,
a locked knee. This is typically mechanical. Something is physically blocking extension, most often. A displaced meniscal tear, like a bucket handle fragment jammed in the joint. That often needs surgery, sometimes urgently.
And the third possibility?
A true flexion contracture. This is a fixed block. Even passively, you cannot get them to 0 degrees. It's often due to chronic stuff, scarring, tight posterior capsule, severe arthritis. Differentiating a lag from a contracture is key. One needs therapy, the other might need a surgical release.
And the flip side, problems with flexion?
Usually less complex. Inability to fully flex often points to a big effusion, just too much fluid in there, or maybe hardware blocking motion, or simply pain limiting the bend.
Okay. And lastly, in this initial observation phase, we're looking at the quads themselves.
Yes, gross quadriceps atrophy. It's a really strong confirming sign. Tells you the patient's been guarding that knee maybe for weeks, maybe months. Or that VMO inhibition we mentioned is chronic. You see visible wasting, especially compared to the other side.
Then you absolutely have to measure it objectively. Mandatory. Leads right into the next step. Objective circumferential measurement. Missing atrophy means you're missing a big piece of the chronicity puzzle. All right, section 2 then. Palpation and getting objective numbers on that effusion and atrophy. Moving from the big picture to the specifics. Where do we start with palpation?
Surface anatomy first. You have got to know the landmarks cold. Feel for Gertie's tubercle laterally where the IT band inserts. Find the fibular head posterolaterally, the medial and lateral femoral epicondyles, the edges of the patella. And, super important, trace the entire medial and lateral tibiofemoral joint lines.
Looking for that pinpoint tenderness?
Exactly, because often the pathology is very localized. Tenderness right on the medial joint line, high predictive value for a medial meniscus tear. Tenderness laterally near the epicondyle might be LCL, a bit more anterior, maybe lateral meniscus. You need to be specific, not just, it hurts somewhere around here.
Okay, and then we deal with the swelling, the effusion. How do we grade that? It can really impact the exam and the patient's comfort.
Right, we use a standard 4-grade system. It's based on compressing the suprapatellar pouch and seeing how the patella behaves. It helps guide whether you need to stick a needle in there. Check figure 3.6.
Okay, grade 1.
Minimal fluid. You might just feel a slight fluid wave if you milk the pouch downwards. Barely noticeable.
Grade 2.
You start to feel a slight lift off of the patella. It's just beginning to float a little off the femur.
Grade 3 is the classic one, right?
The palatable patella. You push down firmly, displace the fluid, and the patella taps against the femur and then visibly bounces back up, like pushing on a small water balloon. Just tap. Repeatable.
And grade 4.
This is the critical one, a tense effusion. The joint is packed so tight with fluid that you cannot compress the patella down onto the femur at all. It feels rock hard, often warm.
And a grade 4, especially after trauma, sets off alarm bells, doesn't it? Potential hemorrhagosis.
Immediately. A tense, bloody effusion post-injury often means ACL tear, maybe an osteochondral fracture, significant capsular injury. Aspiration is often necessary right away, both for diagnosis and just to relieve that intense pressure and pain. It's a barrier to everything else.
Makes sense. Okay, let's get back to that atrophy measurement. You mentioned needing an objective protocol. What is the standard technique?
Standardization is everything if you want to track progress. The key is a consistent reference point. You measure the thigh circumference, exactly 10 centimeters, about 4 finger breadths. For most people, proximal to the superior pole of the patella.
Okay, 10 centimeters above the top of the kneecap.
Correct. And the knee must be in full extension, relaxed. Then you measure the exact same spot on the other, uninvolved leg. A difference of, say, 1 to 2 centimeters or more is clinically significant. confirms the disuse atrophy.
And calf's measurement.
Calf measurement is usually secondary for knee issues. You measure at the point of greatest circumference. It's more relevant for looking for things like a DVT or maybe compartment issues, less specific for tracking quad recovery after knee surgery.
Right. So that thigh measurement gives us that objective baseline for rehab. Now, what about crepitus? That grinding or popping sound?
Crepitus is tricky. Lots of perfectly normal knees click and pop and grind a bit. So crepitation by itself doesn't automatically mean pathology.
But we still need to document it.
Absolutely. The key is location. Where is it coming from? Is it patellofemoral under the kneecap, maybe medial or lateral facet that suggests tracking issues or chondromalacia?
Right.
Or is it tibiofemoral medial or lateral joint line? That points more towards meniscus or arthritis. Generalized, non-tender clicking might just be noise. But localized, painful crepitus, especially over the patellofemoral joint in a younger person, that needs a closer look.
Yeah.
Okay, moving on to section 3. Zeroing in on the patellofemoral joint, often the source of that vague anterior knee pain. Starting with static alignment, the Q angle. Yes, the Q angle, the quadriceps angle. A classic measurement, though, we have to acknowledge its limitations. It represents the general pull of the quad muscle relative to the patellar tendon.
How do we measure it again?
You draw a line from the center of the tibial tubercle up to the center of the patella, and then another line from the patella center up to the ASIS, the anterior superior iliac spine, that bony point on the front of the hip. The angle between those two lines is the Q angle.
And what are the normal ranges? When does it become a concern?
Generally, about 10 to 20 degrees is considered normal. There's data suggesting males average around 14 degrees plus or minus 3, and females slightly higher, around 17 degrees plus or minus 3, likely due to the wider female pelvis.
So the red flag is?
Angles over 20 degrees. That's generally considered excessive. A high Q angle means there's a stronger lateral pull on the patella during quad contraction. This predisposes the patient to patellar maltracking, lateral pressure syndrome, and even instability.
But it's not just about the knee itself, is it? The Q angle is affected by the whole leg alignment, this idea of miserable malalignment.
Absolutely critical concept. You can't just look at the knee in isolation. Miserable malalignment is this unfortunate combination of rotational issues up and down the kinetic chain. Think about femoral anteversion.
The angle of the femoral neck relative to the shaft?
Right. Increased anteversion means the femur naturally wants to rotate inwards. Then maybe you add external tibial torsion, the shin bone rotating outwards, and perhaps shallow trochlear groove or abnormal patellar facet shape. Let's see figure 3.4 for this.
So the hip turns in, the foot points out.
And the poor patella is caught in the middle. The forces pulling it laterally are magnified enormously. That dynamic Q angle skyrockets. It's almost a guarantee for lateral tracking problems or subluxation. A real geometric mess.
So if we suspect that kind of issue, or just patellofemoral pain in general, how do we best palpate for the source of the pain under load?
We use the patellar compression test, but the key is the position. The patella doesn't really fully engage the trochlear groove until the knee bends to about 30 degrees.
Okay.
So you flex the knee to 30 degrees, then apply gentle downward pressure on the patella, maybe wiggle it slightly side to side, and carefully palpate the medial and lateral facets and underlying trochlea, as shown in figure 3.9. This position isolates the contact points and helps you localize tenderness from chondral damage or specific facet overload.
So 30 degrees is key, which brings us to a test we shouldn't rely on, the patellar grind test.
Yes, please. Let's be explicit about this. The classic patellar grind test, done with the knee in full extension while the patient contracts the quad. It's just not very reliable.
Why not?
Well, several reasons. It often hurts even in normal knees, maybe just pinching synovium. Also, in full extension, especially if the patient has patella alta, a high-riding kneecap, the patella might barely be engaging the trochlea anyway, so the test is invalid. Stick with the compression test at 30 degrees of flexion. Much more specific.
Noted. Reliability over tradition. Okay, moving from static to dynamic examination, watching how the patella actually tracks.
Right. Have the patient sit on the edge of the table, legs dangling. Ask them to actively, slowly straighten and bend the knee. You're watching that patella. Does it glide smoothly in the center of the groove?
When does it normally engage?
Typically engages the trochlea somewhere between 10 and 30 degrees of flexion. What you're looking for is abnormal lateral movement, especially as they approach full extension. That's the pathologic J sign. See figure 3.10.
That visible lateral jump at the very end of extension.
Exactly. It looks like the letter J traced by the patella. It's a strong indicator of patellar hypermobility or instability, often seen after subluxations or in those miserable malalignment cases.
After just watching, we add some load.
Yeah, Simple resisted knee extension can sometimes elicit pain or crepitus, but a better functional test is the half squat test. Ask the patient to do a shallow squat, maybe just 30 degrees. Can they hold it? Or does it immediately cause pain? Or does the patella visibly shift laterally? That's a positive sign for patellofemoral issues under real-world load.
Makes sense. We also need to check the static restraints, the soft tissues around the patella, patellar tilt and mobility.
2 key tests here. First, the passive patellar tilt test. Knee fully extended, relaxed. You try to lift the lateral edge of the patella upwards, away from the femur. See figure 3.1.
What are we looking for?
If you cannot lift that lateral edge up past the horizontal plane, if it feels stuck or tethered down, that indicates a tight lateral retinaculum. It's pulling the patella laterally. Okay. This is really important if you're considering surgery for instability. A tight lateral side often needs releasing.
Okay. And mobility, the translation.
You assess this with the knee slightly flexed, around 20-30 degrees, to relax the structures a bit. You gently push the patella medially and laterally. Normal movement should be about 2 quadrants worth of patellar width in each direction.
And if it doesn't move medially?
If you get less than 1 quadrant of medial translation, that's another sign pointing towards a tight lateral retinaculum. It confirms the lateral structures are restricting medial glide.
Got it. And the big one for instability, the apprehension test.
Right. Also done at 20-30 degrees of flexion. You apply firm, laterally directed pressure on the patella, simulating a potential subluxation event. See figure 3.12.
And a positive test isn't pain.
No, critically it's apprehension. The patient will suddenly get anxious, their eyes widen, they might grab your hand, or instinctively fire their quad to prevent the feeling of the kneecap sliding out. That reaction tells you their brain knows this unstable position. It strongly suggests recurrent subluxation or dislocation. Usually we test lateral apprehension, as that's far more common.
But we check medially too.
Always check medially, though medial instability is much rarer. Usually it's iatrogenic, meaning caused by a previous surgery, like an overly aggressive lateral release that made the medial side too loose. Okay, super important point before we leave the patella. The proximal connection. Always examine the hip. Cannot emphasize this enough. It's a classic pitfall, especially with anterior knee pain. Pain can be referred from the hip joint down the obturator nerve. Think about kids with SCFE or Perthes or adults with hip OA. Their knee hurts, but the problem is in the hip.
How do we screen for hip involvement quickly in this context?
Assess hip rotation, usually best on prone. Patient lying on their stomach, knee bent to 90. Check internal and external rotation. Look specifically for excessive femoral anteversion, see figure 3.13, the sign. Markedly increased internal rotation compared to external rotation. Yeah. If internal rotation is more than 30 degrees greater than external, that's pathologic anteversion.
And that feeds back into
that miserable malalignment we talked about. That rotational profile predisposes to patellofemoral issues. So if you find that hip rotation asymmetry, part of the knee problem might actually stem from the hip's alignment. Always clear the hip. Excellent point. All right, let's move posteriorly now into the tibiofemoral joint itself, section 4, meniscal tears. What's the typical story or finding for a meniscus problem? Usually it's pretty mechanical. Patients complain of localized pain right on the joint line, maybe associated clicking, popping, or a catching sensation. The most dramatic presentation, though, is the locked knee.
Where they physically can't straighten it.
Right. Extension is blocked. Usually implies a large displaced tear fragment, classically a bucket handle tear, acting like a doorstop inside the joint. That's often a sign for prompt surgical intervention.
The sources divide the meniscal tests nicely into 2 groups. Those relying on palpation or clicks, and those using rotation and pain. Let's tackle the palpation click group first.
Okay. First up, the Brigard test. This isn't about clicks, it's about accentuating joint line tenderness. Let's say you suspect a medial meniscus tear. You externally rotate the tibia. This brings the anterior horn of the medial meniscus forward, and then slowly extend the knee while palpating the medial joint line.
So the maneuver should increase the tenderness at the site of the tear.
Exactly. And conversely, flexing the knee and internally rotating should move the tender spot posteriorly or make it less prominent. It confirms the pain is coming from a structure that moves with rotation. See figure 3.14 for these tests. Got it. And then the classic click test, McMurray. The McMurray test is specifically trying to elicit that palpable, sometimes audible, click or thud as a torn meniscal flap gets caught between the femur and tibia during motion. For a medial tear, you fully flex the knee, apply valgus stress, externally rotate the tibia.
So you're trapping the medial meniscus.
Right, and then you slowly extend the knee. If you feel or hear that distinct click, that's positive. And where it clicks tells you something. A click early inflection often suggests a posterior horn tear. A click nearer extension suggests a more anterior tear. It's specific, but maybe not as sensitive as simple joint line tenderness.
And the Steinman second test, how does that help?
This test helps differentiate a mobile tear from something fixed, like arthritis. You find the point of maximum joint line tenderness with the knee somewhat flexed. Then as you flex the knee further, does that tender spot seem to move posteriorly along the joint line? And as you extend, does it move anteriorly?
So it confirms the tenderness is tracking with the meniscus itself as it moves?
Precisely. If the tenderness stays in the exact same spot regardless of flexion angle, it's more likely a fixed lesion, like an osteophyte or focal chondral damage. If it moves, you're probably dealing with a meniscal tear that's shifting position. Okay, great distinction. Now for the second group, the rotation and compression tests. These seem more about provoking pain functionally. Let's spend a moment on Apley's test, the grind versus distraction. This feels critical. It is. This comparison, described by Apley back in 1947, is incredibly elegant for differentiating meniscal versus articular cartilage pain. Patient is prone, knee flex to 90. See figure 3.15.
First, the grind.
You push down on the heel, axial compression, jamming the femur and tibia together while simultaneously rotating the tibia internally and externally. If this causes pain, it means something in the joint is getting aggravated. Could be meniscus, could be cartilage.
Okay, then the key is the distraction test.
Now, instead of pushing down, you pull up on the ankle, distracting or separating the joint surfaces while again rotating the tibia. Here's the diagnostic fork in the road. If the grind was painful, but distraction relieves that pain, it strongly points to a meniscal tear. You've taken the pressure off the damaged cushion.
And if distraction doesn't relieve the pain or is also painful?
If both compression and distraction are painful, it favors an articular surface problem, like chondromalacia or osteoarthritis. The thinking is that distraction still stretches the ligaments and capsule around the joint, which can be painful if there's underlying arthritis or synovitis, irrespective of compression.
That's a really neat diagnostic pair. What other compression or rotational tests are useful?
The Bowler test uses stress in the coronal plane. If you apply varus stress, push the knee inwards, you compress the medial compartment. Pain suggests a medial meniscus issue. Valgus stress, pushing outwards, compresses the lateral side for lateral tears.
And testing under body weight.
Weight-bearing provocation is very functional. The classic is duck walking, having the patient squat down fully and try to waddle. This puts massive stress on the posterior horns of the menisci. Inability to do it due to joint line pain is highly suggestive of a posterior horn tear.
There's also the pair test?
Yes, the Turkish sitting position test. Patient sits cross-legged. The examiner gently pushes downwards on the knee. This creates a combined flexion and varus stress, really compressing the posterior medial corner of the knee. Very good for picking out medial pathology back there.
And the Steinman first test?
That's a quick rotational provocation. Knee flexed to 90 degrees, sitting. You suddenly rotate the tibia internally or externally. Sharp pain with external rotation points to the medial meniscus. Pain with internal rotation points to the lateral meniscus.
Finally, if the patient does present with that locked knee, what's the specific test?
The Helfet test. This is only relevant if extension is already blocked. You try to extend the knee passively. Normally, as the knee reaches full extension, the tibial tubercle should rotate externally slightly. That's the screw-home mechanism. If the knee is locked by a meniscus, this terminal rotation fails to happen. It confirms a mechanical block, not just pain inhibition. Okay, that covers the menisci thoroughly. Let's move into section 5, ligament stability, starting with the collaterals. This is crucial for acute injuries. First, the grading system needs to be crystal clear. Absolutely. This is the universal language for ligament injuries. Grade 1, 2, and 3. It's all about how much the joint opens and, most importantly, the feel of the endpoint.
Grade 1.
You apply stress, the joint feels stable, minimal, or no opening compared to the other side, but the patient reports definite pain at the ligament. It's a sprain, a stretch, maybe some microscopic tearing. Non-operative treatment almost always.
Grade 2.
Now you feel some definite opening, some laxity compared to the contralateral side. But, and this is key, as you push, you feel a distinct, firm endpoint. The ligament is significantly torn, maybe partially ruptured, but there's still some structural integrity, maybe secondary restraints are holding.
And grade 3.
This is a complete rupture. You apply stress, the joint opens up significantly, feels grossly unstable, and crucially, there is no distinct endpoint. It just feels soft, mushy, keeps opening.
Yeah.
You've lost the primary restraint completely, often secondary capsular structures too. This usually implies a need for surgical intervention, especially in active individuals.
That endpoint quality is really the defining factor between 2 and 3. Okay, let's apply this. Medial collateral ligament, MCL, tested with valgus stress.
Right. You stabilize the femur and apply an outward-pushing valgus force to the lower leg, and you must test it in 2 positions. See figure 3.16.
First, at 0 degrees, full extension, 0 degrees. Stressing it here tests the MCL and the posterior medial capsule and other static stabilizers. The knee should be rock solid in full extension. If it opens up significantly at 0 degrees, that's a bad sign, a severe, likely multi-ligament injury involving the capsule, grade 3. And then at 30 degrees flexion, now you bend the knee slightly. This relaxes the posterior capsule. Applying valgus stress here specifically isolates the MCL. If it opens at 30 but was stable at 0, you likely have an isolated MCL tear. Could be grades of 3 or 3rd, depending on the endpoint. If it opens at both 0 and 30, you've torn the MCL and the posteromedial corner. Makes perfect sense. And the same logic applies to the lateral collateral ligament, LCL, using varus stress.
Exactly the same principle, just mirrored. Apply an inward pushing varus force. Check figure 3.17, full extension, 0 degrees. Test the LCL plus the posterolateral capsule and corner structures, PLC. Opening here means a complex PLC injury, often involving the LCL too. Serious stuff. 30 degrees flexion. Isolates the LCL by relaxing the posterolateral capsule. If it opens at 30 but was stable at 0, it's likely an isolated LCL tear. If it opens significantly at both 0 and 30, you've disrupted the LCL and the posterolateral corner, a very unstable situation, often needing surgical reconstruction. Okay, collateral's covered. Now for the big ones inside the joint. Section 6, the cruciate ligaments and rotatory instability. Starting with the anterior cruciate ligament, ACL, we have the Lachman in the anterior drawer. Why is the Lachman test generally preferred, considered the gold standard? The Lachman, figure 3.8, is just more sensitive, especially in an acute setting. You perform it with the knee flexed only about 20 to 30 degrees. You stabilize the femur and pull the proximal tibia forward.
Why is 30 degrees better than 90?
Because at 30 degrees, the hamstrings are relatively relaxed. They can't guard and produce a false negative as easily. Also, the angle is thought to better stress the bulk of the ACL, particularly the stronger posterolateral bundle. The key finding isn't just how much it moves, but the quality of the endpoint. Is it firm like the other side, or soft and mushy? That soft endpoint is the hallmark of an ACL tear.
So how does the classic anterior drawer test compare? Figure 3.1 mean.
The anterior drawer is done at 90 degrees of flexion, patient supine, foot stabilized. You pull the tibia forward. It's thought to be maybe a bit more sensitive for the anterior medial bundle. But the big problem is that at 90 degrees, the hamstrings are in a much better position to contract forcefully.
So guarding is a bigger issue.
Huge issue. If the patient is apprehensive or in pain, they'll fire their hamstrings and you'll get a false negative tear. The drawer feels artificially stable. That's why most of us rely much more heavily on the Lachman, especially right after an injury.
There's also a dynamic test using the patient's own muscles, the quadriceps active test for the ACL.
Yeah, this is a neat one, shown in figure 3.21a. Knee flex maybe 30 degrees, heel resting on the table. You ask the patient to try and gently lift their heel off the table, just starting to extend the knee. In an ACL-deficient knee, as the quad fires, it pulls the tibia forward before the knee actually starts extending, because there's no ACL to restrain it. You see that little anterior shift of the tibia. It's a nice functional confirmation.
Okay, now for the really complex stuff, anterolateral rotatory instability, the pivot shift and related tests. These sound intimidating, and you mentioned they're tough acutely.
They are very tough acutely,
Yeah.
because they are provocative tests. They are designed to make the unstable knees subluxate or shift out of place. An ACL tear doesn't just cause straightforward backward laxity. Its main job is controlling rotation. These tests demonstrate that rotational failure.
So pain and muscle guarding get in the way right after injury.
Exactly. You often need anesthesia or sedation to reliably perform these in the acute phase. But in a patient with chronic instability, someone who says their knee gives way or buckles, these tests are absolutely essential to demonstrate that functional rotational instability that needs fixing.
Let's break down the pivot shift test, figure 3.22. How does it work? Okay, you start with the patient's knee in full extension. You apply a combination of forces, a valgus inward stress to gap the lateral side, internal rotation of the tibia, and sometimes a bit of forward pressure near the fibular head. So you're trying to make the lateral tibial plateau slide forward.
Precisely, because the ACL isn't there to stop it. As you then slowly flex the knee while maintaining those forces, the lateral tibial plateau, which was subluxated anteriorly, will suddenly reduce back into place, usually around 20-30 degrees of flexion. This reduction happens with a palpable, sometimes audible clunk. That clunk is the positive sign. It's the IT band snapping over the condyle as the geometry changes with flexion, pulling the tibia back into place.
Wow, okay. And the jerk test, figure 3.23, is it similar?
It's essentially the reverse. You start with the knee inflection, apply the same forces, internal rotation, valgus, maybe for pressure to subluxate the lateral tibia anteriorly. Then, as you slowly extend the knee, that reduction clunk happens as you approach full extension. Same phenomenon, just initiated differently.
And the Luzi test, figure 3.24, another variation.
Yeah, Luzi tried to accentuate the subluxation. You start near extension, but hold the tibia in external rotation initially. Then as you extend further, you quickly internally rotate it, trying to really maximize that feeling of the tibia shifting and then clunking back into place upon full extension. They're all variations on a theme, demonstrating that anterolateral rotational instability.
What about the flexion rotation drawer test, figure 3.20?
Similar concept, often done with the patient supine. You hold the knee in slight flexion, 15-30 degrees, and feel for that anterior subluxation of the lateral plateau, often associated with internal rotation of the femur relative to the fixed tibia, followed by a reduction or clunk as you adjust rotation or flexion. Again, demonstrating that rotational instability near extension.
Okay, that covers ACL and anterolateral instability. Let's switch gears to the posterior cruciate ligament, PCL. Similar testing principles.
Very similar. We have the posterior Lachman, figure 3.25, done at about 30 degrees flexion, where you push the tibia posteriorly, and the posterior drawer, figure 3.26, done at 90 degrees flexion, again pushing posteriorly.
Which one is more key for PCL?
The posterior drawer at 90 degrees is really the main PCL test, primarily because we use the amount of posterior translation at 90 degrees to grade the severity of the PCL injury.
Okay, let's detail that PCL grading system. It sounds crucial for surgical planning.
It is. It's based on how far the front edge of the tibia sags or can be pushed back relative to the front edge of the femoral condyles. Grade 1, there's increased posterior translation compared to the other side, but the tibia still rests anterior to the femoral condyles, often treated non-operatively. Grade 2, the anterior tibia translates posteriorly until it's flush or level with the femoral condyles. This indicates a complete functional tear, more likely to consider surgery. Grade 3, this is gross instability. The anterior tibia translates posterior to the level of the femoral condyles, just drops way back. This almost always means you've torn the PCL and other structures, usually the posterolateral or posteromedial corner. It's a complex multi-ligament injury requiring surgery.
And just like atrophy for the quads, is there a visual sign for chronic PCL tears?
Yes, the posterior sag sign. Patient lies supine, hip flexed to 45, knee flexed to 90. You look from the side. In a PCL-deficient knee, gravity will often cause the tibia to passively sag backwards, creating a visible contour difference, a step off compared to the femur.
And the quadriceps active test works for PCL too, figure 3.21b.
Yes, but differently. You do this one at 90 degrees of flexion, where the sag is most apparent. Ask the patient to gently contract their quad, like trying to slide their foot down the table. Because the tibia is already sagged posteriorly, the quad contraction will pull it forward, reducing the sag before any actual extension happens. It's a dynamic confirmation of the PCL's incompetence.
Very clever. Okay, finally, assessing the corners, the posteromedial and posterolateral capsules. These sound like they get injured with more severe trauma.
Absolutely. These are often missed in complex knee injuries if you don't specifically test for them. They provide critical rotational and varus valgus stability, especially near extension.
How do we test the posteromedial capsule? We use the Slocum test, figure 3.27. It's basically an anterior drawer test done at 90 degrees flexion, but with one key modification. You externally rotate the patient's foot and tibia about 15 degrees. Why external rotation?
External rotation tensions the medial structures. If the posteromedial capsule is torn, performing an anterior drawer in this position will result in increased anterior translation, specifically of the medial tibial plateau, compared to doing the drawer in neutral rotation. The tibia tends to roll out anteriorly.
Okay, and for the posterolateral capsule, figure 3.28.
It's the mirror image. You do the anterior drawer at 90 degrees, but this time with the tibia internally rotated about 15-30 degrees. If the posterolateral structures are insufficient, you'll see increased anterior translation, especially of the lateral tibial plateau, compared to neutral. The tibia tends to roll in. anteriorly.
Got it. Now, the dial test. This sounds specific for differentiating PCL from PLC injuries based on the angle.
Extremely specific and very important. Patient is prone, knees flex together. You stabilize the femurs and passively externally rotate both feet tibias, comparing the amount of rotation side to side. You do this at 2 angles.
First at 30 degrees.
Yes. Increased external rotation asymmetry, more than 10-15 degrees difference. At 30 degrees of flexion points, specifically to an injury of the posterolateral structures, PLC. Why? Because at 30 degrees, the PCL itself provides less rotational restraint.
And then at 90 degrees.
Now you flex the knees to 90 degrees and repeat the external rotation comparison. If the asymmetry is significantly increased or only appears at 90 degrees, that points primarily to a PCL injury, because the PCL is a major restraint to external rotation in deeper flexion.
And if it's positive at both angles.
If you have that increased external rotation asymmetry at both 30 and 90 degrees, that's the worst case scenario, a combined PCL and PLC injury, a major instability requiring complex reconstruction.
Okay, that's a critical differentiator. What about the hyperextension recurvatum sign, figure 3.29? Sounds dramatic.
It looks dramatic too. It confirms severe posterolateral instability. You lift the patient's legs straight up by the great toe. In a knee with significant PLC injury, the knee will fall back into hyperextension, recurvatum. The tibia will drop posteriorly and will often externally rotate. It's a visual confirmation that the structures preventing hyperextension and external rotation in the posterolateral corner are gone.
And lastly, the reverse pivot shift test, figure 3.30. Is this the PCL-PLC equivalent of the ACL pivot shift?
Exactly. It confirms posterolateral instability. You start with a knee flexed, around 70-90 degrees, and the tibia externally rotated. This combination often causes the lateral tibial plateau to subluxate posteriorly relative to the femur.
So the opposite of the ACL pivot shift.
Right. Then, as you slowly extend the knee while maintaining some valgus stress and external rotation, usually around 20-30 degrees of flexion, you'll feel a palpable clunk as the subluxated lateral plateau reduces back into its proper position. That clunk is the positive sign for posterolateral rotational instability, indicating deficiency of the PLC. Seeing that means complex surgery is likely needed.
Wow. Okay, we've covered the entire circuit. From just watching them walk in, to palpation, effusion, patellar tracking, meniscal tests, and finally these intricate ligament and rotational stability exams.
It's a lot, but walking through it systematically is key.
Yeah.
And the take-home message really has to be that this detailed physical examination is absolutely vital. It's what should guide your thinking and your treatment plan, not the other way around.
Completely agree. The exam tells you about function, about dynamic stability or instability, in a way that a static picture from an MRI just can't. We really can't afford to become clinicians who just order scans and read reports without that hands-on assessment.
The imaging should confirm what you already suspect based on your history and physical. It shouldn't be generating the diagnosis from scratch. If you do the exam right, you should be able to predict those MRI findings with pretty high accuracy before you even see the images.
And that skill, that clinical proficiency, directly translates to better diagnoses, more appropriate treatment plans, knowing who needs therapy, who needs a scope, who needs a major reconstruction, and ultimately better outcomes for our patients. Feeling that grade 2 on endpoint versus the grade 3 mush, that's often the decision point.
It really is. That tactile feedback, that's the art that complements the science.
Which leads us perfectly to our final thought for you listeners to chew on. Consider how understanding these very specific, sometimes complex biomechanical tests, the pivot shift, the dial test comparing 30 and 90 degrees, the logic behind Apley's grind versus distraction allows you, the clinician, to perform dynamic, functional diagnostics. You're assessing how the knee fails under specific stresses, something a static image simply cannot do. So the question to ponder is, if the knee, with all its intricacies, demands this level of hands-on functional assessment even in the age of advanced imaging, where else in the musculoskeletal system is this tactile expertise perhaps even more critical? Where else must we absolutely trust our hands and our clinical reasoning above all else, resisting the siren song of just ordering another scan? Something to think about. That's our deep dive on the clinical knee exam. Keep practicing, keep palpating. Until next time.